This is part 2 of our conversation with Nadine Burke Harris. We recommend first listening to part 1. Welcome to Pathways, Becoming Trauma Responsive, where we explore trauma through a compassionate lens, discover how these experiences affect each of us differently, and dive deeper into what it really means to become more trauma-informed. I'm your host, Dr. Elizabeth Meeker, Senior Director of the New York State Trauma Informed Network and Resource Center, funded by the New York State Office of Mental Health. The network advances the collective understanding of trauma, wellness and healing, and trauma-informed practices in action. This podcast is produced by CCSI. The views, opinions, and content expressed in this podcast do not necessarily reflect the views, opinions, or policies of the New York State Office of Mental Health or CCSI. This is a special edition of Pathways, where we travel outside of New York State to hear and learn from national experts.
I often like to say, because of what you've experienced, your body is maybe making more stress hormones than it should. And that can look and feel like being quick to anger or getting sick easily when you're overwhelmed, or having trouble controlling your impulses. And then just check in. And does any of that feel familiar, right? Most often, what I find is yes. In fact, the number one reaction that I have received in my clinical practice was, "Oh, you mean I'm not crazy?"
Yeah.
And I think that for many providers, the fear can be that if you talk about the impact of ACEs, that it can be, people can feel like they're broken, or it can be kind of, I think sometimes I hear from folks that, oh, it feels deficit based. And my own experience is the opposite.
Yeah.
Over and over and over again, what I have gotten from families, and I think it is important to take a strengths-based approach, to say, hey, you know what, your body, that's your body's way of protecting you. That's actually a normal biological response to the things that you have been through, right? But one of the things that can happen is that can continue to happen in ways that are not so helpful later on down the line. And the good news is there's lots that we can do about it. In fact, when we look at some of the best practices, sleep, exercise, nutrition, mindfulness, mental health, time in nature, healthy relationships, which of these are you already doing? And let's make a plan to double down on the ones that feel really good to you, right? And then also just make a plan as to how we incorporate this into your life in a way that is supportive, right? Of you. And I find, honestly, I think that it's really helpful for people to feel seen and acknowledged and not broken. They don't feel, I think that there's certainly strength-based ways to approach it, so that you're not telling people that you're broken, but rather you're identifying that they've experienced an injury and that we can work together to heal that.
Yeah. I think, as you're describing that, it's such a collaborative, empowering approach, right? It's kind of naming their experience. They're already experiencing it. Now you're giving words to help to understand it, to normalize it, that this is to be expected given what you've gone through. And there's things that you can do and build upon what you're already doing to help promote your healing and recovery.
Right.
Yeah.
Right. And what's really powerful about it is that I think that understanding the science of ACEs and toxic stress, I find for a lot of people, it's like a bell you can't unring, right? Because folks start to notice for themselves, for example, oh, these experiences, these dynamics, I tend to get triggered around X, Y, and Z in work, right? When my boss, talks to me in this certain way, or with my spouse, right? With my partner, this is where I notice that this situation impacts me in one way, or my spouse has their own ACEs. And so it's a way to begin to, number one, understand what your triggers are and then get support for yourself, right? And so that's really what the focus of a lot of this work is about.
Absolutely, yeah. So I'd love to learn more about your rollout in California, because New York State has already started to embark in the same direction of being able to do these ACEs screening. And, so love to be able to learn more about kind of your experience in rolling that out and training folks. And, what I'm hearing too is it's much more than about the screening. That's a part of it, but it is only a part of it. So I'd love to hear more about that.
Yeah. So I'll jump in and talk about the second piece first, which is that there's like all kinds of like rumors and misconceptions going on around ACE screening. And the thing that I want to clarify, what California implemented is a model called ACEs Aware.
Mm-hmm.
And it involves, there are three kind of critical parts to the ACE screening component. Now, we talk about ACE screening because right now, ACEs are the most evidence-based way to assess risk of toxic stress, right? And the whole point is identifying whether a patient or an individual is at high, intermediate, or low risk of having prolonged activation of the biological stress response and that neuroendocrine, immune, and genetic regulatory disruption, because that's treatable. So that is what the goal of it is, to identify. I think some of the misconceptions are that, why screen for ACEs if these things happened in the past, right? Well, right now, we don't have a lab test for toxic stress. The best, most evidence-based way is to assess an ACE history, because what the ACE, we understand that an individual with 4 more ACEs really has a dramatically increased risk of lifelong health challenges, from all the way from asthma to Alzheimer's, right? And so we're not sure. It's based on someone's individual biology, right? And so the next part of the ACE screening, in addition to the ACE score, is looking at ACE-associated health conditions. And the ACEs Aware initiative has a whole list pull from the scientific research. So, for example, eczema, increased risk of like inflammation in the skin. That's an ACE-associated health condition. That may be a sign that someone with high ACEs may be manifesting, for example, an immune or inflammatory component. But obviously, other things like anxiety, depression, like I mentioned, asthma, other health conditions. So that piece is key. And then the third piece that is key to the doing the ACE screening in the ACEs Aware model is assessing for strengths and protective factors. So like one of the broad misconceptions that I hear all the time is like, ACE screening doesn't include protective factors. And it's the ACEs Aware model that California uses. I'm sure there are some people out there who are doing it a different way.
Right.
But the ACE screening model that California uses does incorporate assessing for protective factors. Now, we don't have the data on the odds ratios to say, okay, if you have, for example, if an individual has experienced 4 more ACEs, their risk of ischemic heart disease is 2.1. But if you have these 4 protective factors, what does that do to your odds of ischemic heart disease? We don't know that. And so we haven't built that into the toxic stress risk assessment. But it's a key piece, because that's where you start your treatment, right? Is looking at the protective factors, supporting the protective factors. And if someone is low on protective factors, then you definitely want to supplement and incorporate protective factors. So that piece is really key. The other piece that is also really key. And this is why, like, you'll see the super science nerd in me come out. Part of the reason that we keep the we use the items where we have odds ratios, right? Like why are when we say these are ACEs and these are risk factors for toxic stress, because if a person has 4 more ACEs, we know the odds for different things. Well, part of the way that we were able to get the resources for our response. So here's the thing that I'm really excited about. In California, a child who has 4 more ACEs, we changed the eligibility when we launched the ACEs Aware initiative. They have access to specialty mental health and wraparound services with no other qualifying diagnosis.
Okay.
So we changed the eligibility to be based on risk rather than based on harm, because what the science shows is that early detection and early intervention improves outcomes, right? And if we identify who's at risk for having a toxic stress response and we intervene early, then we actually get to take advantage of the developmental trajectory of the brain, right? To be developing in the context of a more responsive, nurturing environment, right? So that's exactly what you want from a scientific standpoint. But I'll tell you, when we did these changes, I had to go to the governor's office and I had to go to the legislature and I had to say, hey, listen, when we use these 10 ACEs, I can tell you now the odds ratio for heart disease and stroke and cancer. I can tell you the cost. And I actually went to them. We did a cost analysis. And the cost to the state of California, the annual cost of ACEs was $112.5 billion per year. That was how we were able to get, the providers reimbursed, the money for the money to build a system. You have to be able to prove, right? Like beyond a shadow of a doubt. So this is why the ACE data was powerful, not just as a clinical tool, identifying who's at risk of toxic stress, but also as a policy tool to say, this is how much it costs the state.
So I'm wondering, now that it sounds like you're 5 years into ACEs Aware, like what have you learned from this? And are there what are some of the outcomes that you're seeing?
So there are a couple of things that we've learned. So the first thing is kind of like a surprisingly basic insight, but you'd be surprised, is that it's totally doable to screen. I say this because I think I think that piece is something that was really important. Like I said, California's trained 43,000 clinicians. Wow. About 3.7 million ACE screens have taken place in California. So more than a quarter of California's kids on Medicaid have been screened for ACEs. And there are a couple of really exciting things that were happening. So number one, we're seeing increased eligibility, increased access to those wraparound services. And really fascinating, because many of those kids who are being eligible through the result of their ACE screen, it actually is kind of like working the exact way we would want it to work. They don't have another eligible diagnosis, right, for wraparound care. And so what we're finding is that, and I'm going to say the system doesn't work perfectly, but what we're finding is that when many of these kids are eligible, right, if they don't have a mental health diagnosis, they actually don't necessarily need to be seen by a licensed mental health provider, right? So they can be seen by a community health worker or a promotora, and we can actually do this thing that we would love for healthcare to do, which is prevention, right? So if these community health workers are again trained, and so ACEs Aware is training not only providers, primary care providers, but also doulas, community health
Oh, I
workers,
love that. Yeah.
promotoras to be able to deliver evidence-based,
Mm-hmm.
trauma-informed care. And the program is working to get
Mm-hmm.
them eligible to draw down payment for Medicare for their services, from
Wow.
Medicaid, not
Yeah.
Medicare,
Okay.
Medicaid,
Aid. Yeah.
from their services. So it's really around transforming our systems.
Mm-hmm.
The other thing that we're finding is that the biggest thing, people think it's about the screen. When you put a line in the sand like we did in California and said, we're going to reimburse our providers for screening, we're going to train them how to screen, and we're going to really work on transforming our systems, what we saw was an incredible level of capacity building
Mm-hmm.
to respond to a positive screen.
Yeah.
So, unfortunately, it's all too common that if a provider doesn't feel equipped to respond to a
Mm-hmm.
positive screen, they won't screen,
Right.
right? But then, of course, which is very understandable, but the result of that is that number one, we just don't identify
Mm-hmm.
the early adversity as a risk
Right.
factor. Or number two, we end up waiting until the patient is symptomatic,
Mm-hmm.
which is like, it's a little bit like saying, okay, we're going to treat breast cancer when it's symptomatic,
Right.
right? When you've got fever and night sweats and you've lost 20 pounds and you've got a big lump in your breast. And
Mm-hmm.
it's like the result of that is that patients have worse outcomes,
Right.
right? So it's like you're more likely to be stage 4,
Mm-hmm.
and the 5-year survival for stage 4 breast cancer is 32%.
Yeah.
But the problem with that is that it makes both providers and patients feel like it's untreatable,
Right.
right? Whereas we know that the 5-year survival for stage 1 breast cancer is greater than 99%,
Mm-hmm.
right? ACEs and toxic stress really fall into this category of things like the science is clear.
Right.
Early detection and early intervention improves outcomes, but the biggest obstacle to that early detection is our clinical capacity.
Yeah.
Do providers feel equipped? Do they feel like they're trained? Do they feel like they have the resources? And do they have someplace to refer, right?
Yes.
And so this is why some of the systems work
Mm-hmm.
that we've done in California is so important.
Absolutely, absolutely. And I love that you kind of brought light to that, because it isn't just something, that lives with one system, with the medical care providers or behavioral health providers or any, people are interacting with all parts of different systems. And it's really a community approach. And so who are the people, if there is a positive screen, and then also it doesn't necessarily mean a referral to therapy. It could
Right.
mean other types of services and supports to wrap around a family, and it makes so many more options.
Exactly. So
Yeah.
there's actually, and one of the things that we know, right, is actually, I think that the way that I see this work happening best. So number one, I am so excited to see the way that more educators are understanding their roles as delivering the daily doses of safe, stable, and nurturing
Yes.
relationships and environments for kids. We're not asking educators to screen. In fact, because we know how much training it takes, right, to be able to respond to a positive screen, we're actually like one of the things is really getting clear as to what is the role of educators in the ecosystem. It really is providing those daily doses of
Right.
care. We know the role of our mental health providers is providing evidence-based, trauma-informed interventions, right, to be able to treat trauma, which we know there are some really good interventions out there. The role of primary care is to do that screening so we can do that early detection and early intervention. If you're waiting for someone to be symptomatic or to show up in a mental health setting, right, then that's pretty late.
Yeah.
And so there's one of the other exciting things. We had a clinical pilot that happened in Los Angeles, where providers in primary care, did the ACE screen, and they actually had patients. So this is it's kind of like the ADHD example. So they actually had a cohort of patients who had high ACEs and who scored high on their PHQ-9, right? So they were
Mm-hmm.
screening high on depression symptoms. And they did a primary care intervention of a mindfulness intervention, which, as we know, is an
Mm-hmm.
evidence-based intervention for for helping to regulate the stress
Right.
response. And with this, and this was a virtual mindfulness intervention,
Uh-huh.
and they saw reduction in PHQ-9 scores, right, with just
Wow.
this mindfulness intervention,
Mm-hmm.
right? And so, like, I don't know about how y'all are doing in New York, but we don't have like all of these mental health providers who are just laying around
Right.
without anything to do.
Uh-huh.
So the idea of like there is a
Yeah.
a role in like the primary care provider, and this I think is really key.
Mm-hmm.
I'll say I think the toxic stress response, you can tell I'm getting excited about this
Yeah.
because I love to see this work happening, and I
Right.
love to see so many clinicians advancing our standard of care. One of the things I think is really key is that while it's the role of our mental health colleagues to be really delivering the trauma interventions,
Mm-hmm.
things like child parent psychotherapy or trauma focused CBT, all of these
Right.
interventions, the important role of the primary care provider is to treat the dysregulated stress response.
Mm-hmm.
Because if we don't treat the dysregulated stress response, these other interventions, and whether they're mental health interventions, social support, or even delivering protective factors, will only be partially effective,
Yeah.
right? So it's a little bit, the way I liken it is we know that, for example, people with HIV have an increased risk of pneumocystis pneumonia or Kaposi
Mm-hmm.
sarcoma or like,
Right.
so if you're treating those things and you're not treating the HIV,
Right.
you're only going to be partially effective.
Mm-hmm.
And the same thing, we see that a person with four more ACEs, again, 4.5 times the
Yeah.
risk of depression. So if you're treating the depression, but you're not treating the dysregulated stress
Yeah.
response, well, you're going to see is it's only partially effective. And actually, that's been borne out in the science. There are studies that show that SSRIs, which are like a very standard treatment
Sure.
for depression, are only 50% as effective at achieving remission of depression in individuals with four more ACEs,
Mm-hmm.
right? So this is where it's really important for us to understand that underlying biology and
Absolutely.
really take this, multidisciplinary approach.
Yeah, yeah. It's just such an important point of just how taking that holistic approach and really get to the root. Because I know in my own kind of clinical care, it's like you'll see this before I knew about the science. It's like you're treating one symptom that kind of settles down, but then the new symptom pops up because you never treated the underlying issue of the dysregulated nervous system. So yeah, yeah, absolutely. So I could keep talking to you all day because, like you, I love talking about this and just find it so interesting and fascinating. But I do know that our time is coming to a close. So, I just wanted to ask, like, kind of some last thoughts, the gem that you want to leave us with as we come to the close of our conversation.
Yeah, I mean, so first of all, I would just say that I am so heartened by seeing how much progress this field has
Yeah,
made, even in the last 10 years,
yeah.
right? And when I think about where we are going um, with early detection and early intervention,
Hmm.
screening for, ACE screening in primary care to identify risk of toxic stress, and then clinical teams working in actual clinical and community partnerships,
Yeah.
right? To treat that dysregulated stress response and support families in being able to heal. That just, it's so exciting to
Yeah.
me And we all have a role to play.
Yes.
So I would say, their role, if you're a clinician, right, that's learning about this and understanding the tools that really help to treat a dysregulated stress response is really important. But also, if you're a parent, if you're a caregiver, if you're an educator, if you're a policymaker, right, we all have a role to play in transforming the outcomes for the next generation. And so that feels really exciting to me.
It does feel really exciting. And a great place to end. And I just want to thank you again for your time, for everything that you've done for the field. As you were reflecting on the change in the last 10 years, I just think the role that you've played in that. And I just want to express my personal thanks and gratitude for that. And just thank you so much.
Oh, thank you. It's really a pleasure. Thank you.
Thank you for joining us today. Please visit our website, traumainformedny.org, for additional trauma-responsive resources, events, and training opportunities. Subscribe to our podcast to be notified when our next episode is released.